is Anushka Burde. I'm a pharmacist and also a faculty member at the Idaho State University College of Pharmacy. And so my area of practice is HIV, hepatitis C, and community pharmacy. So with that, let me try to share my slides with you guys. Can somebody please make me the host or the co-host? Because I'm unable to share my slides. Oh, there. Okay, now it's working. Okay, can you guys see this? Yes? Okay, perfect.
Yes, we can see that. Could you click on that slide presentation? Perfect. Okay.
Okay, perfect. Well, today's topic is medications in chronic liver disease. So the objectives for today is to be able to recognize the pharmacokinetic and pharmacodynamic changes that occur in the liver in case of advanced fibrosis. You should be able to recognize factors which should affect the choice of your selection of medications. Utilize the Child-Pugh score to be able to adjust medication dosages, and then know how to manage different classes of medications in chronic liver disease or cirrhosis. And so we will kind of go over some of the more commonly prescribed medications, such as pain medications, statins, acid-reducing agents, antihypertensives, and hypoglycemic agents. So now it is important to know that there are no current set guidelines or prescribing information which can essentially tell us, this is the dose of the medication that needs to be used in this patient. And so clinicians kind of, face the challenge of, maybe safely prescribing medications in chronic liver disease because there is not adequate information. And so just kind of putting this presentation together was kind of a bit hard because I had to go through a lot of different studies and literature to be able to come up with recommendations for those certain different drug classes. Now, before I move on to the main slides, I do want to maybe provide a brief overview of some of the metabolic pathways and elimination pathways of the liver to be able to clear some of the medications. And so if you guys remember, what is first pass metabolism is when somebody takes an oral medication, it is absorbed through the GI tract, and then from the GI tract, it is then transported to the liver via the portal vein. Now, inside the liver, for drugs which are metabolized through the first pass pathway, usually most of the drug is actually metabolized into inactive substances, and only a portion of the active drug is released back into the systemic circulation. And so that kind of helps the body only get certain amount of active drug, and the remaining inactive drug is then eliminated from the liver first via phase 1 reaction, where the drug is either oxidized or reduced or hydrolyzed in order to be created into inactive substances. Then those inactive substances move on to something called as phase 2 reaction, where additional molecules such as glucuronic acid or glutathione or sulfates are added onto those inactive substances to make them more water soluble and then eliminated either via the kidney or the stool. So it's important for you guys to remember what is first pass metabolism and then phase 1 and phase 2 reactions, because I will be using a lot of these terms as I go through my presentation. Now, the hepatic drug clearance depends on 3 different factors. So there's the hepatic blood flow, metabolism by hepatocytes or liver enzymes, and then the fraction of the unbound medicine, which depends on the quantity of plasma proteins. Now, in the setting of cirrhosis, what happens is in the liver, there is restricted hepatic blood flow. There is a lot of vascular resistance, and so the hepatic blood flow is significantly reduced. So medications which actually depend on the hepatic blood flow for clearance actually are not cleared efficiently because there is restricted blood flow. For example, naltrexone depends on the hepatic blood flow. In the setting of cirrhosis, what happens is because the hepatic blood flow is reduced, naltrexone levels go up pretty high. So it's about 5-fold in somebody who is a compensated cirrhotic and about 10-fold in somebody who is decompensated cirrhotic. Now, there are medications which depend on the metabolism by the liver enzymes, such as, for example, PPIs. Now, proton pump inhibitors such as lansoprazole or pantoprazole depend on something called as, let's say, CYP3A4 system, specifically CYP2C19 enzymes. And so in the setting of cirrhosis, what happens is the activity of those hepatocytes or the liver enzymes is significantly reduced, which is why a lot of these drugs are not metabolized into inactive substances, and the concentration of those drugs go up pretty high. And then in the setting of advanced fibrosis, what happens is that the number of plasma proteins is also pretty low. So medications which are highly protein bound, for example, let's say phenytoin or something like paroxetine or PPIs, which actually depend also on plasma proteins such as albumin. Now the fraction of unbound medication is pretty high, which results in toxicity. Now, this table just kind of shows you the actual pathophysiological changes that occur in the liver in the setting of cirrhosis and what implications it could potentially have on the drugs. So, for example, let's think about absorption. So, in cirrhosis, there is impaired gastrointestinal motility with delayed gastric empty. So, this results in decreased rate of absorption of the medication. It also results in something called in altered hepatic blood flow, which basically decreases first pass effect, resulting in higher bioavailability of medications. There is also decreased levels of plasma proteins such as albumin, as I mentioned before. And so medications which are highly plasma protein bound, now the fraction of those unbound drug is pretty high, resulting again in increased risk of side effects and adverse effects. There is also actual alterations in the architecture of the liver, including hepatocellular necrosis and altered blood flow. And so this also reduces the enzyme activity or the liver enzyme activity, which is usually responsible for the breakdown of these medications into inactive substances, which is why, again, because those enzymes are not present as much as we want, or they're not as active as we would like them to be, the drug levels are pretty high because they're not getting metabolized. And then at the end, usually people who have advanced cirrhosis usually have issues with their kidneys as well. There is renal impairment. And so you also need to think about medications which are renally excreted, are not cleared to the extent that we would like them to be. So it's not just about the liver, but eventually the kidney can also be damaged in advanced fibrosis or cirrhosis. Now, the other changes that can occur in the setting of cirrhosis is, for example, renal effects. So usually what happens is because of the portal hypertension, the organs which are supplying blood flow, such as the pancreas, GI tract, the stomach, which is supplying blood flow to the portal vein, there is a lot of vasodilation in the arterioles of those organs. So what happens is your body automatically activates your renin, angiotensin, aldosterone system. And so when people who have cirrhosis, usually when they're given medications such as NSAIDs or RAS inhibitors, try to inhibit the prostaglandins and the angiotensin 2, which is a vasoconstrictor, which is released, causing acute renal failure as well, or injury. Now, patients with cirrhosis also kind of experience neurotoxicity. They can have confusion or hepatic encephalopathy in some patients with advanced cirrhosis. So the proposed mechanism is that there is altered permeability of the blood-brain barrier. And this is contributed to probably the high levels of bilirubin, which actually downregulates something called as P-glycoprotein efflux pumps. And so the P-glycoprotein efflux pumps are pumps which actually help metabolize medications. And when they are downregulated by high levels of bilirubin, then there is increased risk of passage of those medications across the blood-brain barrier. There is also increased affinity and or density of receptors in the brain. There was actually a study which looked at increased levels of benzodiazepine receptors in the brain in some patients, which is why the effects of benzodiazepines was pretty high in those patients. And then in these patients, there is also increased levels of neurotoxins such as ammonia, which can easily pass through the blood-brain barrier and cause a lot of inflammation. The other effects are immunological effects. So patients with cirrhosis actually are in a constant state of immune dysfunction, proposed to be because of alterations in GI motility and permeability. And so patients usually end up so patients with cirrhosis usually end up with are at high risk of infections, especially if they are on immunosuppressive medications such as interferons, which nowadays we don't use interferons a lot, maybe sometimes in chronic hepatitis B treatment. But these patients are just at really high risk of infections. And then even patients who are on long-term proton pump inhibitors or PPIs are at risk of infections as well as spontaneous bacterial peritonitis. And then the last one is thought to be hematologic effect. So because of portal hypertension, there is hypersplenism, there is reduced thrombo and erythropoietin synthesis or reduced growth factors, and then impaired synthesis of procoagulation and anticoagulation factors, which essentially results in cytopenias, for example, with specifically medications such as azathioprine or interferon, and then ribavirin itself actually has a black box warning of hemolytic anemia, and it seems to be really more pronounced in patients with decompensated cirrhosis or advanced cirrhosis. Now, when you decide to choose a medication in somebody who has chronic liver disease, you want to kind of think about different factors. So you want to think about the indication for drug therapy. So what is the underlying diagnosis that the patient has? And is this medication required for long-term treatment in this patient? You also want to think about the pharmacokinetics of the medication, such as metabolism of the medication or the elimination of the medication. You want to think about safety of alternative medications, coexisting conditions such as renal impairment, as I mentioned before. So patients with decompensated cirrhosis also have renal impairment issues. And so you want to think about dose adjustment of medications which are renally cleared as well. And then think about concurrent medications because of potential drug-drug interactions, and then severity of liver disease. So this is important. So we actually have to calculate the Child-Pugh score, or something called as MELD, which is Model for End-Stage Liver Disease, in order to be able to adjust medications based on the references or resources that you guys use. And then again, empiric dose reduction is recommended with obviously close monitoring in these patients. So this is just an example of how you calculate Child-Pugh score, and I'm pretty sure most of you are already familiar with it. So there are online calculators where you basically just plug in all those different things, such as albumin levels, prothrombin time, bilirubin, and all of those, and that calculator will give you a Child-Pugh score. So just to kind of remind you, a Child-Pugh score of 5 to 6 is basically that there is mild impairment of the liver, and a MELD score, you can actually even calculate a MELD score for that matter. It depends on what resource you'll be using, and I'll kind of tell you why. So a MELD score of 1 to 10 means, again, mild impairment. A Child-Pugh score of 7 to 9 means it's Child-Pugh B, and that means there is moderate impairment of the liver, and that correlates to a MELD score of 11 to 20, which is also considered moderate. And then a Child-Pugh score of 10 to 15 is Child-Pugh C, and that's considered severe impairment with a MELD score correlating to greater than 20. And so usually a Child-Pugh score of A is when somebody has compensated cirrhosis and mild liver impairment, as I mentioned before, and Child-Pugh score B and C is considered decompensated cirrhosis. And why is this important? So why is it important to calculate Child-Pugh score or MELD score? Because a lot of the resources that you will come across, so for example, a pharmacist use quite a lot of Lexicomp. I think other providers probably use a lot of UpToDate. But most of them usually will kind of have you calculate Child-Pugh score to decide what dose of medication the patient should be recommended. So I kind of just threw in these examples. For example, lansoprazole, it says you have to calculate a Child-Pugh score. So if they have a Child-Pugh score of A or B, then you do not have to adjust the medication dosage. But if they have a Child-Pugh score of C, then they should get a maximum of 15 milligram per once a day. So the same goes for UpToDate. I kind of just looked at venlafaxine, and it just says that Child-Pugh A and B, you have to reduce the total dose of venlafaxine by 50%. And then if they have a score of C, then the maximum recommended dose for venlafaxine extended release is 112.5. So my point is that you have to know these scores or classifications to be able to adjust dosages of medications in patients with chronic liver disease. Now, this is also one really good resource that I think most providers, I think you probably are already familiar with it. I use this quite a bit. So it's called LiverTalks. And so essentially what you do is you just actually put in the name of the medication that you're concerned about in a particular patient, and this is what it'll show you. So I just took a snapshot of, let's say, naltrexone, for example. You want to know if naltrexone would be safe in somebody who has liver disease, what is the risk of hepatotoxicity? And this is what you will get. And the thing that I want to point out is that it actually gives you something called as likelihood score, which you can see right here. It's right there. And the likelihood score is E for naltrexone. And so what is a likelihood score? It actually tells you if the medication is the actual cause of maybe liver damage, or if it's not really much related to the liver damage. So likelihood score of E is basically that naltrexone is the unlikely cause for liver damage. Now, if it has a likelihood score of A, then that means it has been known to cause liver damage pretty often in a lot of studies. So I would highly recommend maybe always using LiverTox as one of your resources if you have questions or concerns about adjusting dosages of medications or using medications in chronic liver disease. Now let's move on to pain management. There is a lot of misconception of using acetaminophen in somebody who has chronic liver disease. In fact, I've had patients come to me and say that, I was told that I have hepatitis C, and that's why, because it affects the liver, I have decided not to take acetaminophen. However, there is some truth to that, but it's not completely accurate. It kind of actually depends on the patient, right? So if acetaminophen is taken in appropriate doses, it is actually considered one of the safest analgesics in patients with cirrhosis, unless they are consuming alcohol on a daily basis. If they are using other narcotics, such as, let's say, oxycodone, acetaminophen, or hydrocodone, acetaminophen, and then you also want to think about the total dosage of acetaminophen that they may be getting in a day. And then there are a lot of over-the-counter medications such as cold and cough and allergy medications which have acetaminophen in them. And so you kind of want to make sure that the total dose that the patient is getting is not exceeding the one that is usually recommended in those with liver disease. So I think this flow chart is, kind of important because it actually walks you through the metabolism of acetaminophen. So acetaminophen is primarily broken down. 90% of it is broken down via the phase 2 reaction, if you remember. So what happens is there is addition of glucuronic acid and sulfates, and it is then made into a water-soluble product and then excreted via the kidney. Now, less than 5% of acetaminophen is actually broken down by the cytochrome P450 enzyme into something which is more of a reactive metabolite. Now, because of phase 2 reaction, there is something called as glutathione, which is present in your body, right? So glutathione actually binds to this reactive metabolite and then makes it more water soluble and gets rid of it through the kidney. What happens is, in those people who consume alcohol, the cytochrome P450 system is highly induced. So what that means is that it's actually trying to pull the acetaminophen into more reactive metabolite pathway as compared to the glucuronic acid and sulfate metabolite pathway right here. Okay, so in alcoholics, the CYP450 system is highly induced, which tries to pull the acetaminophen into more reactive metabolite. And in people who drink alcohol, the levels of glutathione are also pretty low, which is why the reactive metabolite is then not made into an inactive metabolite. Instead, what happens is that the reactive metabolite is converted into something called as NAPQI metabolite, which is basically toxic. Now, there was a study which looked at 6 patients who consumed about 4 grams of acetaminophen for 5 days. And they noticed that there was no evidence of drug accumulation or hepatotoxicity in those patients. There was another study too, which looked at 20 patients with chronic liver disease who consumed about 4 grams of acetaminophen for about 13 days. Only 1 patient had transient elevation in their AST levels. But when their AST level came back down, they were re-challenged with acetaminophen for about 10 to 14 days again. And they noticed that there was no elevation in transaminases. However, it is important to note that these patients in both studies were not actively drinking alcohol. Now, it's a different situation when patients are actually consuming alcohol. So there was a retrospective study which looked at about 67 patients who were consuming alcohol. 60% of those patients were consuming less than 6 grams of acetaminophen, and 40% were consuming about less than 4 grams of acetaminophen. However, it was important to note that in these patients, 90% of them had elevated liver enzymes. Specifically, I think the AST levels were like somewhere from 3,000 units per liter to 48,000 units per liter. So it was pretty significant elevation in those liver enzymes. They also had a lot of severe hepatic necrosis, and then 20% of those patients died. So the difference between the first two studies and this study was that the patients were actually drinking alcohol. There was another study which actually had some confounding results, in the sense that it was a randomized controlled trial where 102 patients were given about 4 grams of acetaminophen for 2 days. There was no elevation in the liver enzymes. However, what was not known was whether these patients were admitted into an alcohol detoxification program, or if they were actually drinking alcohol. If there was a question also about whether they had advanced liver disease, if they had an INR greater than 1.5, which means that they probably had maybe preserved liver function. And so really, I mean, the bottom line is that maybe acetaminophen is not safe in patients who have chronic liver disease and who are actually actively drinking alcohol. So in my practice, what I do is, so I see a lot of patients with chronic hepatitis C. And so as long as they are not actively drinking alcohol, I am okay with them taking about 2 grams of acetaminophen. However, if they have cirrhosis of the liver, then I actually tell them to restrict it to maybe up to 1 gram of acetaminophen. However, patients with chronic hepatitis C and other liver disease, if they are actively drinking, should not be taking acetaminophen. And then you also want to think about narcotics and over-the-counter cold and flu medications, which have acetaminophen as well, in addition to the separate acetaminophen that they might be taking. Now, NSAIDs, on the other hand, so I actually have a lot of patients who actually prefer or take NSAIDs because they have heard that they should not be taking acetaminophen. However, they need to be educated that NSAIDs actually can also be equally bad, especially if they are cirrhotics. And so what happens is, as I mentioned before, NSAIDs inhibit the production of prostaglandins in the GI mucosa. They also inhibit production of thromboxane, leading to decreased platelet aggregation and increased risk of bleeding. And so in the setting of ascites, especially in advanced cirrhosis, the diuretics are also not really working very well, and it promotes sodium retention, worsens ascites and edema. And so the recommendation is basically do not recommend NSAIDs in patients who have cirrhosis. Now, there is some question mark about the COX-2 selective NSAID, which is celecoxib, because it is thought that the celecoxib may not have as much renal impairment or GI effects, GI or bleeding effects, basically. However, the cardiovascular effects of celecoxib are still a question mark. And so maybe, I mean, if they have to take a NSAID, maybe you could potentially recommend celecoxib at 50% the dose, as long as they don't have maybe cardiac history. Now let's move on to opioids, which we see also quite often in practice. So just to maybe remind you guys, opioids are metabolized again by the two pathways, so phase 1 and phase 2. So phase 1, if you remember, is the oxidation, and then the phase 2, which is addition of the molecules such as glucuronic acid, right? So opioids basically are cleared depending on the levels of plasma proteins, hepatic blood flow, and hepatic enzyme activity. In the setting of cirrhosis, again, as I mentioned before, a lot of these different factors are messed up, which is why the excretion of opioids is also pretty low. So the general recommendation is opioids have to be used cautiously in somebody who has advanced liver disease. It is preferred to use maybe the immediate release formulations as compared to extended release, because I think with the extended release formulations, they will probably stay in the body way longer in somebody who has chronic liver disease as compared to maybe the immediate release formulations. And then try to use extended dosing intervals such as every 6 to 12 hours. Now let's look at the most commonly prescribed opioids in practice. So tramadol is hepatically metabolized to active metabolite by the CYP3A4, CYP2D6, and glucuronidation pathways. And so the onset is unpredictable. Again, the analgesic effects are variable and there is risk of accumulation. Also, tramadol itself can actually cause seizures, especially maybe in patients who have a history of seizures. And so it actually lowers the seizure threshold. It also sometimes interacts with serotonergic medications such as SSRIs and TCAs. And so the recommendation in chronic liver disease is that you have to avoid use of tramadol in somebody who has decompensated cirrhosis. You could use maybe 25 milligrams every 8 hours in those who have compensated cirrhosis. And then hydrocodone and oxycodone, again, we see this quite a bit in practice. It is also metabolized into active metabolites by the CYP3A4 systems. The onset is prolonged. There is variable analgesic efficacy and there is risk of accumulation. You also want to think about that these two medications are usually combined with acetaminophen, and think about the total daily dosing of acetaminophen in these patients. So the recommendation is avoid extended release formulations and then reduce the dose and frequency of these medications. Morphine, the bioavailability is increased by 100% due to reduced first-pass extraction or first-pass metabolism, as I mentioned on my first slide, and the half-life can be increased by up to 2-folds. So morphine is actually broken down into 2 active metabolites, which are renally excreted. And so in the setting of cirrhosis, if these 2 active metabolites are not easily cleared, because let's say somebody who has decompensated cirrhosis may also have kidney issues, then those metabolites can result in neurotoxicity such as confusions, seizures, and respiratory depression. So the recommendation is, again, avoid extended release formulations of morphine, reduce the dose by about 50% in somebody who has advanced chronic liver disease or cirrhosis, and then titrate the dose gradually to avoid accumulation of the drug. And then avoid it, especially in patients with cirrhosis and renal failure, because of those 2 active metabolites which are renally excreted. And then codeine, again, there is decreased enzyme activity in somebody who has liver disease, and that enzyme is usually responsible for the breakdown of codeine into active metabolites. There is also unpredictable analgesic efficacy, and then there is increased risk of toxicity. So you want to avoid codeine in patients with chronic liver disease or cirrhosis. And then meperidine, which I don't see very much often in practice, but sometimes, however, it is extensively metabolized in the liver and actually can cause accumulation of pretty toxic metabolites. Again, it's highly protein bound. And as you remember, the levels of plasma proteins are pretty low in somebody who has cirrhosis, which is why that the fraction of the unbound drug is much higher in these patients. Again, there is unpredictable analgesic efficacy, and then there is increased risk of toxicity. So you want to probably also avoid this medication in somebody who has chronic liver disease. Now, fentanyl, on the other hand, interestingly, is actually generally a good choice for patients who may have advanced disease. It is metabolized by the CYP3A4 system to inactive metabolites. It is preferred in renal failure in the setting of cirrhosis. If you are recommending just a single dose, no adjustment is really needed. However, if the patient is going to be on fentanyl multiple times, then you want to think about maybe reducing the dose of fentanyl by about 25 to 50%. If you are considering using transdermal dose, you want to reduce the dose by about 50%. Now, hydromorphone, again, not seen much, at least I don't see it much, but of course it's used for pain management. It is 5 times more potent than morphine. It is actually considered a good choice for patients with advanced liver disease. And it is also, again, preferred in renal failure in the setting of cirrhosis. However, it is important to maybe consider reducing the dose by 50% and slowly titrating the medication. Now, methadone, actually, we see that quite often, especially these days, not just for pain management, but a lot of patients are on it also for opioid use disorder. It is a long-acting opioid. Interestingly, methadone is actually seems to be pretty safe in cirrhosis. The half-life is mildly prolonged, however, in somebody who may have more severe cirrhosis. However, short-term administration seems to be okay in these patients. Now, this is just a chart that I found in one of the literatures for your references. I'm not going to go over specifically the dosing for each and every medication, but this is something I kind of provided you guys in case if you want to ever look back at it, if you have a patient who may be on these different meds. Now, statins, there is a lot of concern about statins elevating liver enzymes. And so in the study, there was a study which looked at NAFLD patients and chronic hep C patients and patients with cirrhosis, specifically, I think, compensated cirrhosis. And they found out that the statin-induced liver injury was no different as compared to the cohort which actually did not have liver disease. So in general, statins are actually okay in patients who have chronic liver disease as long as they are not decompensated. And on the right, you can see there's a little picture that I kind of threw in there to show you the importance or the importance of statins in terms of prevention of cardiac diseases, right? So in, however, decompensated cirrhosis, what happens is that there is reduced expression of this transporter called as the solute carrier organic anion transporter, or SLCOB1. In these patients who have decompensated cirrhosis, because the levels of this transporter are low, this transporter actually is responsible for the uptake of statins. In these patients, what happens is that there is increased serum concentrations of the statins because of reduced expression of that transporter, which could potentially result in rhabdomyolysis or hepatotoxicity. And so in general, what happens is you do not want to withhold statins in patients who have stable chronic liver disease, because in fact, the literature has shown benefits of statins in these patients in terms of decreased portal pressures, in terms of maybe reversing or reducing the cirrhosis or the progression of the cirrhosis. And because of anti-angiogenic properties, it also reduces the risk of hepatocellular carcinoma or liver cancer. So the recommended statins would be pravastatin and rosuvastatin, which are maybe not metabolized through the liver as much as atorvastatin or simvastatin and lovastatin. And so in your patients, I think you would be okay recommending something like pravastatin or rosuvastatin if they have liver disease. You want to maybe avoid medications such as atorvastatin or lovastatin and simvastatin, as I mentioned before, because those three statins are pretty heavily metabolized through the liver. And now, however, it is a different situation in decompensated cirrhotics, or if their total bilirubin is greater than 1.75, then you probably do not want to use statins in those patients and may consider the risks versus benefits and may have to consider stopping the statins in decompensated cirrhotics. So in general, do not withhold or do not stop yourself from initiating statins in patients who have liver disease as long as they are not decompensated. Now, proton pump inhibitors, I mean, we see PPIs quite a bit. Pretty much every patient of mine who has chronic hep C, I mean, all of them pretty much are on PPIs. The problem with PPIs is that they are metabolized again by the CYP2C19 system. And as I mentioned before, the liver enzymes or the CYP2C19 system activity is pretty reduced in somebody who has advanced cirrhosis, which is why the levels of PPIs goes up, right? Because they're not metabolized, because that enzyme system is not very much active, which results in increased risk of the infections such as C. difficile and SBP. And the proposed mechanism is that because the PPIs create more alkaline environment in the gut, usually it results in overgrowth of bacteria, which again puts the patients at risk of all those different types of infections. PPIs have thought to also result in something such as hepatic encephalopathy, And so the recommendations are you can safely use omeprazole, esomeprazole, and rabeprazole in somebody who has Child-Pugh A and B. However, it's better to use esomeprazole in somebody who has Child-Pugh C. And so again, reminding you why it is important to calculate Child-Pugh scores or MELD scores, because it helps you decide which medication to pick in those patients. In general, you want to avoid omeprazole, pantoprazole, lansoprazole in patients who have more advanced liver disease. And then H2 blockers, again, I usually avoid cimetidine in general and not just in patients with chronic liver disease, because the problem is that cimetidine itself actually inhibits the CYP3A4 system, which is why it can actually increase levels of other medications. And it is also have thought to cause hepatic encephalopathy in patients with cirrhosis. So in terms of H2 blockers, I think it's okay to use famotidine. You may also want to think about dose adjustments in patients who also have kidney issues as well. And then I would just probably avoid cimetidine in patients with cirrhosis. Also think about drug-drug interactions in patients who may not have liver disease. And then antihypertensives, basically ACEs and ARBs should be avoided in patients with cirrhosis and ascites, because it actually can cause significant hypotension in these patients. However, low doses is okay in patients with cirrhosis without, however, ascites. And then thiazides really do not increase risk of adverse reactions in patients with chronic liver disease. However, thiazides actually have, kind of affect the electrolytes and can cause something like hyponatremia or hypokalemia, which is thought to result in something such as hepatic encephalopathy. And then thiazides should really rarely be used in cirrhosis, because they are not really great in terms of diuretic effect in these patients. And then calcium channel blockers, you want to probably use certain calcium channel blockers where you can adjust the doses if needed based on the liver function and kidney function. You want to use the lowest effective dose, and you want to avoid maybe something such as nifedipine or diltiazem, which are extensively metabolized by the liver. And then at the very end, I think hypoglycemic agents, in general, I think most of them are pretty okay in liver disease. So insulin is generally considered safe. The pharmacokinetics, are largely unchanged in the setting of cirrhosis. Now, metformin, on the other hand, maybe should be avoided in somebody who has decompensated cirrhosis and maybe a risk factor for lactic acidosis, such as renal impairment or alcohol use, because metformin, if not cleared from the body appropriately, can result in risk of lactic acidosis, which is quite rare, but however, it can possibly happen in patients with decompensated cirrhosis. And then sulfonylurea, such as glipizide, are highly metabolized in the liver and also are highly protein bound. And since in patients with decompensated cirrhosis, because the albumin levels and protein levels are pretty low, there's again increased risk of concentrations of these medications. And can again, if present in excessive levels, can put the patient at really high risk of hypoglycemia. And then DPP4 inhibitors, I think you can use them pretty cautiously, however, not preferred in Child-Pugh class C. And then SGLT2 inhibitors, I think, which we actually quite see often in practice, I think they're okay to use as long as you titrate them slowly. And then really, usually, typically, no dosage adjustment is needed with these agents in advanced cirrhosis. And then pioglitazone, interestingly, should be avoided in decompensated cirrhosis, because if you guys remember, one of the side effects of pioglitazone is actually fluid retention and edema. And so patients with decompensated cirrhosis already are at really high risk of ascites and fluid retention. And so pioglitazone maybe should be avoided in those patients. But however, it is okay to use it in compensated cirrhosis as long as they don't have edema or fluid retention. So basically, those are my key points. Summary, I don't think I'm going to repeat all of these because it just basically summarizes all my slides. Any questions?